Thank you. What Paul has asked me to talk through is some of the work that we've been doing in the Bradford area over the course of the last few years. And one of the key things was to look at some work we did 3 or 4 years ago. And Paul was quite keen research-wise to just talk through the methodology of what we did and where we got to. And the importance is we didn't actually get anywhere successful, but actually there's quite a lot of learning by the process that we took, taking on board some of the things Mike was talking about earlier with regards to IEPT. So 3 or 4 years ago, I approached my local CCG wanting to do some work really trying to integrate physical and mental health. And what I was trying to get across to them was that the significant amount of mental illness that's within the communities and how spending in the NHS is very much dominated on physical health services. So if we say 20% or so of recognised illness is mental health, we're only funding about 9% at this moment in time. And what I was trying to do was to look at patients with physical problems, underlying mental health problems, and see if we could come up with some projects to do something different. And what I want you to think about here as I go through this is just the process was about how we selected patients. So these are some of the slides I used in my initial talk to the CCG, which was from the King's Fund. And the King's Fund paper was about integrating physical and mental health. And what it was stressing at the time was about the importance of where money is being spent. So no surprise to anybody, the significant amount of mental illness is usually in younger people. As we pass through life and we get older, we develop more physical health problems. But there is a significant overlap between mental and physical problems. So the smaller circle here relates to 20% of the population have a mental health problem. The larger circle is 30% of the population have a long-term condition. And when you put the two together, it's about 46% of patients with long-term mental health problems also have a physical long-term condition. And on the other side, 30% of patients with long-term conditions also have a mental health problem. And so the correlation between the two. In the King's Fund's paper, it also describes what the associated costs are of patients with specific long-term conditions, and if they have underlying mental health problems, how the costs actually escalate. So you can think if you've got heart disease or COPD or asthma and you're anxious, you're more likely to turn up in a blue light ambulance to the local A&E unit with actually a panic attack because of your underlying anxiety, and you can see how the costs of this can quite quickly escalate. The other key one was really relating to how if you have increasing numbers of long-term conditions, your costs will escalate if you have underlying mental health problems. And what we tried to do at the time was to take this on board and say, okay, there must be lots of people using physical health services with long-term conditions that are not being picked up. And actually, if we can identify people who've got anxiety and depression using this data, what we should be able to find is lots of patients that we can help and reduce their costs. This was a sort of starting point of the approach to the project. And the initial plan was to really use the local IAP service. And initially what we were looking at was an MDT approach to long-term disease management within primary care. So could we find, using the tools such as the risk stratification tool, patients who were going in and out of hospital, and if we could then use the tools such as PHQ-9, GAD-7, identify these patients and see if we could actually then offer some form of therapy within the practice and alter their behaviour. So that was the sort of premise of where we were. We identified the patients at risk. As I say, the key at the time was really about focusing on patients' wellbeing. We actually got a medical student, a counsellor and a CPN to look at the registers in 3 practices, and we found people on the disease registers with 3 or more long-term conditions. They did a questionnaire, they used the validated tools, and actually what did we find? 100 patients were assessed, a third declined to be seen, only 10% were suitable for intervention, and all of them declined any help at all. And actually the feedback we got from the patients at the time was, actually we're getting quite a good service from the surgery. We can get an appointment if we need one. If we need help, we get it. We've got good support from our families. And all stated that they felt that their healthcare, they were getting what they wanted at that time. And we decided, unsurprisingly, to not continue with that approach. And the approach we took instead, we worked with Professor Alan House at Leeds, and we sat down with Alan and said, Alan, this is where we've got to, what should we do from here? Alan went off and did a literature search for really what could be done in primary care, and we came back with a rough proposal which was not necessarily, we weren't in any way saying to the team that we put together, this is what you must do. It really was, here is a list of patients that within the surgeries, these are high cost patients. The GPs in the practice who know them have said they probably have an underlying mental health problem or issues from the past. We put together a GP in each practice, psychologist, psychiatrist, OT and physio, and they went off and worked with these patients. And the initial academic studies showed that this had been effective. So one of the key things is always about trying to show that you are being effective both clinically and financially. And actually what the team demonstrated in the early part of this was significant changes in patients' behaviour. So there was a lady who was supposed to, or was due to get a custodial sentence because of her repeated attendances at A&E and causing problems. This was avoided. There was people, a significant number, who had physical operations that were due to take place that were postponed. And so savings were demonstrated. And what we did demonstrate was significant reduced use in secondary care. So frequent attenders in A&E, their attendance significantly reduced. Referrals into secondary care were stopped, stroke postponed, and as I say, operations were cancelled. What did we find? Significant amounts of adverse childhood experiences, specifically related to sexual abuse. In the first cohort of 30 patients, from what I recall, 4 of the patients had undiagnosed autism. Well, my understanding is the reason they were repeatedly attending is that they couldn't process the information, and actually what was found was by actually diagnosing that and offering other things, their behaviour ultimately could be changed. One of the things that has shone through all of it has been the significant presentation within these patients of long-term chronic pain. And our next stage now is we've set up a pilot specifically about offering a chronic pain service for these patients. It has been recognised nationally. We won, well, the team won an award at the Positive Practice in Mental Health in November last year as the best example of integrating primary and secondary care services.